Good afternoon, everyone. Today, it's my great pleasure to share our recent progress in establishing an interventional psychiatry program in order to create new opportunities for psychiatry research, education, and service. As a faculty, I do have some collaborations with industry, but none of them will be presented here as any advice for the service. Mental health crisis has been one of the major public health issues globally. We're facing increasing challenge, and it might be because several things that have been the roadblocks, such as we do not have a really objective diagnostic criteria, no lab test or biomarkers to help us, just like other specialties in medicine. And we have a really not that great treatment response. Even the patient with respond to the treatment, there's significant delayed response, and many patients will take months to notice the difference, pose a significant burden to the families, to themselves, and also to the society. We need a much better options and for better mental health care. So in my mind, we really need something to can help us to recognize the patient's mental health issues and then to provide early intervention. And we need an accurate diagnosis that guide us to provide a personalized treatment. And the treatment need to be effective and with minimal side effects. Treatment need to be rapid, and the benefits need to be long-lasting. So to achieve all those ambitious goals, we need to really come with some new concept and set up new targets and eventually implement new technologies. That is why we come up with something called Interventional Psychiatry Program. This idea was first brought up by Dr. Williams in the States in 2014. It's pretty new if we put into the history of psychiatry. Interventional psychiatry refers to a procedure treatment and complex to administer and not provided the most practicing psychiatrists. So roughly there are several categories, such as the neuromodulations, like the traditional one we use as ECT, and also RTMS and other newer version of neuromodulations. And also the medication is normally not going through oral route, but use it like nasal sprays or IV injections, things like that. And the most significant example is ketamine. And the third category is medication and neurofeedbacks and virtual reality assisted psychotherapy. And so as we know, this neuromodulation is probably the most known interventions that's beyond medication that in psychiatry practice. And this picture showed quite a different variety of neuromodulations that's being applied or under investigation. And from the most invasive one to the most non-invasive one. And also it showed a different level of precision, or called spatial resolution, and from the very precise, like ultrasound, and also the surgical part as a DBS, to very broad or general and global treatments like low field magnetic stimulation. So this demonstrated how fast and how diverse that neuromodulation has been developed, and how we can really take advantage of their diversity and also the different concept behind the treatment. So another part is medication. So we know that ketamine and the new medication called brexanolone are the non-conventional treatment that has been applied in our clinical practice. They're not going to be taken by oral, but using in IV or nasal spray. And psychedelic assisted psychotherapy probably one of the most the hottest topic that for the last few years, and it involves using psychedelics or hallucinogens, and to create an altered conscious state and to facilitate the psychotherapy. So most commonly used substances such as psilocybin, DMT, LSD, and MDMA. So this one, the psychedelic psychotherapy, was first developed by a non-for-profit group called MAPS. And they started to use MDMA. And we can see for the last few years, and psychedelic psychotherapy has gained significant attention and accomplished many clinical trials, as they show here. And FDA of the United States have put both MDMA and psilocybin as a breakthrough approach and for fast tracking approval. So that's why psychedelic psychotherapy has drawn great attention, and the significant research interest has been developed for the last few years, and will continually become the most attractive areas in psychiatry. So the third part of that is, let's see, how are we going to incorporate new technologies, and including biofeedback and virtual reality or augmented reality into our practice. And here we can see that the EMDR, the eye movement desensitization and the reprocessing, is a device-guided approach for reorganizing our memories and emotions, and it's being broadly used to treat PTSD. And other more straightforward things like virtual reality have been used to treat quite specific phobia. And we're going to talk a bit more about 3MDR. 3MDR is a mixed reality. That means that in the virtual reality plus the in-person psychotherapy, and using multimodal concept to help patients going through their PTSD treatment. So 3MDR actually was first invented by Dr. Eric Vermont, and from the Netherlands, Leiden University. We've been working together quite closely on multiple projects. And this new modality, or the new treatment, actually incorporates multiple treatment concepts into one therapy, including virtual reality, exposure therapy, and cognitive reprocessing, as well as a supportive and explorative psychotherapy. So with all those new ideas, new concepts, and new technologies available, how can we make the interventional psychiatry better option or for the future, and also for our current need? So to really bring up the values of different approach, we have to really think about how we can give the patient the best care, which is a care that's fit to the patient's need. So in that case, we have to really talk about precision medicine. So precision medicine or precision psychiatry means that we need to really find a way to give an accurate diagnosis based on each individual's features. And the diagnosis will help us and to find the matched treatment and to deliver the best care that we can. So it comes from several different process. That means first we have to really shuffling around the existing diagnosis, and then to look at that from different angles and interact with other diagnostic approach, such as neuroimaging and EEG, or at times we need a genetic background, and to really combine and create a profile for each individual. And those profiles need to go through a very big process using machine learning or deep learning or any other artificial intelligence approach, and to come and also find out the clue and to help us to identify each individual with matched therapy. So I've been working with my colleagues from China and trying to identify different approach to rethinking or recategorizing our current conditions. And we have published several papers and saying that how we can even recalculate depression, anxiety, depression, bipolar, and schizophrenia using neural images. By doing this, we actually blurred the boundaries between these three among these three different conditions, and using the new categories and a new approach. And when we match them with different treatment, we significantly improved neuromodulation, such as RTMS effects in certain groups. So taking that into account, so once we have a pretty accurate diagnosis, and we need to have some treatment that can be delivered individually and meet the individual's need. So that's why we call them precision intervention. So here we can see that although we have different treatment, and at this moment, probably the best we can deliver a individualized treatment is neuromodulation, because it's temporal, spatial, and contextual precision that we can see from here. And we can choose a different site for the stimulation, and we can combine different patterns of the treatment. And also we can use different patterns as a sequence or combination to add on the different side. So in this case, quite a lot of combinations. And the neuromodulation can be easily combined with medications, with psychotherapy, to come with quite rich variety of options so that we can match with different individuals. So based upon this, and our interventional psychiatry actually set up and trying to accomplish several things here. So first is we really want to redefine our current care in psychiatry and target on treatment-resistant population to provide innovative, combined, or complex treatment for the best outcome. So to achieve this, and we did a very thorough resource scanning to look at what do we have in terms of the existing categories or existing approach and can be put into this interventional psychiatry, such as RTMS, ECT, and EMDR and ketamine treatment, and what the space need, and how we can attract donations and support and to help us to achieve this goal. And after that, once we identify the existing technologies and expertise, and we start to build the team together and with a common goal. So the team that we currently build at our university included of many psychiatrists and psychologists and other researchers and other healthcare professionals, and they come from the existing neuroscience institute and our neuropsychiatry research unit, our computational psychiatry team, and our rehab medicine. And they come from different background and bring different expertise to this. So we also created a very broad collaborations that's from the multi-center psilocybin trials and to our dear colleagues who invented 3MDR, and also to other professional that's in the nation who's the ketamine expertise. And also we also bring a lot of significant researchers that's in the world and in neuroimaging and in machine learning and in neuromodulations to help us to build the capacity and also to create the projects that we can benefit from each other. So after identify all of the strengths, and we decided that to compete and also to make a unique program, and we will be focusing on several things that are less available in other universities or in other countries, which including the 3MDR and also low field magnetic estimations. This is a newer treatment and only available in few universities in the world. And also the ultrasound treatment, and we have a really strong ultrasound research and institutes here. And we also have a long history of collaboration, as well as psychedelics and cannabis research. And because of our legal and political movement in Canada, it really makes us much easy to access to all this available treatment than other countries. And also University of Alberta is one of the leading university in artificial intelligence. And we have been taking advantage of that and building a computer psychiatry. And we're among the best in the world in terms of applying AI in psychiatry research. So altogether, and we create an interventional psychiatry program and aim to have a team-based multidisciplinary and multimodal approach. So multimodal approach, as we mentioned, so we intended to put neuromodulations, pharmacotherapy and psychotherapy, and also virtual reality all together, and as a combination or as a sequence treatment, and for each individual patients based on their features and also their need, and from a precision diagnostic or precision interventional perspective. So this is a technology we have on our side, that's from more traditional ECT, RTMS, TDCS, to more exploratory and innovative low-field magnetic simulations, focused ultrasound, and also 3MDR. We also build up the facilities for psychedelic assisted psychotherapy, and to occur and in line with or in combination with all different technologies here. And also we're one of the few sites that in the world has this up-to-date and advanced 3MDR equipment, also the personnel who can deliver significant care and using this technology. So by putting all together, and we have many objects ongoing, which including psychedelic assisted therapy, and when part of the global trial that's ongoing. And we also have the EMDR combinations and all different things that we're trying to do, and to combine the different innovations and for PTSD, for depression, for addiction. And currently, we have another really relevant project, which is how we can use this novel treatment to help our patient who went through COVID and developed PTSD. So overall, we have quite a lot of effort on bringing new measurement, and also focused on different populations, such as pregnant women, and also the military and the veterans, as well as the adolescent patients. So overall, we're trying to build up a psychiatry program that's represent the future, and also to strengthen up our existing and technologies and our strength as a university. We really welcome our colleagues here and far away, and to collaborate with us, and to build up something that can truly help the care for the patient in the future. And if any comments and suggestions, please let me know. And you can send to my email and to contact me. And I really appreciate your attention, and thank you very much.